Health. We're about to get started. I see a number of folks still joining the webinar, so I think we're just going to give it maybe 2 more minutes and then we'll get going. Thank you. Hello, folks. We'll be monitoring questions and questions submitted through the Q&A function as well as the chat function throughout the presentation. So please, if you have a question or Q&A, it'd be very helpful to us if you could submit that to all panelists. With that, I think we're about to get started. Hello, and thank you for joining us. This is Kevin Quinn, Senior Vice President of Sales and Account Management for AMC Health. Welcome to today's webinar regarding our money-back guarantee for our post-discharge transition of care program, a program that has been shown to significantly reduce all-cause 30-day readmissions. Today we will examine the value that technology brings to even the best post-discharge programs, especially with regard to the efficiency of your clinical staff and the program's ability to scale, control costs, and achieve your organization's desired outcomes. We'll then share with you our experiences deploying these technologies with a broad range of payers and providers in Medicare, Medicaid, and commercial settings, and we'll look at why these programs work and what we've learned about their use in these diverse populations. It is this experience and knowledge base that gives us the confidence to offer this money-back guarantee. Before we begin, I'd like to provide you a brief overview of AMC Health, who we are, and the services and solutions that we offer. We just celebrated our 10th anniversary. In addition to interactive voice response programs, such as the one we'll be discussing today, we provide remote biometric monitoring, two-way video for remote patient visits, medication management, and personal emergency response services. All of our services and solutions are designed to enable clinicians to connect with patients in a more meaningful way, based on the data received from the home, and address the gaps in care, motivational challenges, and clinical deterioration before patients land in the ED or hospital. Dr. Maria Lopes is unable to join us today, so John Holland, our Senior Vice President of Research, will present an overview of telemonitoring and the origins of our post-discharge program. Then, Rosemary Glavin, our Senior Vice President for Clinical Services, will explain the details of the program, and John Shankman, our Vice President for Analytics, will discuss the mechanics of the money-back guarantee. At the end, we'll save time to take any questions you may have.
Thank you, Kevin. I think that remote patient monitoring works via 2 major pathways. First, data from patients at home provides clinicians with an early warning that a patient may be decompensating before they need to call the ambulance. This may be biometric readings such as blood pressure, weight, blood glucose, or oxygen saturation, or it may be symptoms reported by the patient. The key here is to turn raw data into meaningful, actionable information and to make sure the right clinician sees it at the right time. The second reason remote monitoring works is that it helps patients do a better job managing chronic diseases. Most chronic care, medications, exercise, diet, and the like, is delivered by the patient. Remote monitoring helps engage patients, and by associating outcomes with behaviors, helps them become more accountable. It also improves both lifestyle and medication adherence, and finally, teaches them to be aware of symptoms that call for clinical intervention. At a high level, avoiding readmissions can seem relatively simple. First, identify gaps in care and early signs and symptoms of decompensation, and then deal with the problems. When we get into the details, of course, things become a bit more complicated. The program we're discussing today had its origins in a completely manual process developed by the Geisinger Health Plan in Pennsylvania. Before patients were discharged from a hospital, Geisinger used an algorithm to identify those at high risk of readmission, looking at factors such as comorbidities, prior admissions, age, social isolation, multiple medications, and the like. After discharge, nurses called these patients to identify and close gaps in care and to address decompensation. The program was very effective, but Geisinger nurses spent far too much time on the phone, and the program was not scalable. The solution was to use technology to identify problems. We developed a series of automated telephone calls to the high-risk patients. These calls did the work that nurses were doing in the original manual program, asking about gaps in care and symptoms of decompensation. Depending on the problem, clinical or non-clinical staff would follow up with the patients. If a change to the care plan was needed, the nurses consulted with the patient's provider. One of the Geisinger clinicians who helped develop this program commented that without this technology, staffing would have been challenging, and that it freed nurses to work at the top of their license while other personnel dealt with non-clinical processes. After using the IVR program for 3 years, the Geisinger Center for Health Research conducted a study of its effectiveness, comparing IVR plus care coordination to care coordination alone. Logistic regression was used to model the effect of the IVR program on the probability of a 30-day readmission. Propensity score matching was used to create a retrospective control group based on sex, age, CMS risk score, history of chronic diseases, hospitalization, and cost. The study compared 30-day readmission rates for 875 patients in the IVR group with the rates for patients who had care coordination only. The results were striking. In an intention-to-treat analysis, the risk of readmission was reduced 44%. The relative reduction in readmission rate was 19.5%. The actual rate of readmission dropped from 20.5% in the control group to 16.5% in the IVR group. Now, I'll turn the program over to Rosemary Glavin, AMC Health's Senior Vice President for Clinical Operations.
Thanks, John. I'll start with how the IVR technology works. Patients receive automated phone calls or text messages. The IVR asks questions about gaps in care, such as, did you fill your new prescriptions? Do you have a follow-up appointment with your healthcare provider? Is it of your surgery red or oozing? It also asks about symptoms of decompensation, such as shortness of breath or swelling. Bad or negative answers are assigned different alert levels according to their urgency. Call schedules can be customized for patient convenience, and alerts are posted on our web portal as soon as the patient hangs up. We have considerable experience with a variety of remote patient monitoring technologies, which has helped us develop the knowledge base that fuels our confidence as to why this works. As John mentioned, this is all about identifying pre-acute events and critical gaps in post-discharge transition of care far enough upstream of an adverse event when inexpensive resources can still solve the problem. Otherwise, you learn about them with a call from the ER. These warning signs must be detected early. Without an automated process for timely collection of this information on a scale that enables all patients at risk of readmission to be heard from, the clinical staffing required is prohibitive. Having advanced knowledge of specific issues that are identified by IVR calls allows live callbacks to be more efficient. We know patients are not always available during a care manager's office hours, as we all face the challenges of unable to reach or unable to contact. But IVR schedules can be customized to call patients at their preferred day or time in their native language. Lastly, reporting. And by that, I mean all the information collected through the system. Provides the data to modify the program for optimum adherence and effectiveness. I think some of the metrics we've collected tell an interesting story. On average, it takes 3.5 IVR attempts to reach a patient. That would have been 3.5 calls a clinician would have had to make to obtain the same information. We've also determined that the average IVR call length is 2.3 minutes. Compare that to a live call that can take between 5 and 20 minutes, including the manual documentation. With IVR, the documentation is automatic. The average compliance rate in any given week is 78%. while 89% of patients complete at least one IVR call. The most common clinical issues we see are symptoms such as the patient reporting that they are unsteady, they have diarrhea, nausea and vomiting, and complaints of new pain. Now, these alerts do diminish over time because the IVR answers drive intervention. We work with each of our partners to evaluate readmission data to fine-tune the IVR templates. If patients are being readmitted due to falls, then we would ask questions to flag fall risks. For one of our customers, pneumonia was a source of readmission, and we modified the IVR accordingly. Each IVR call ends asking the patient if there are other issues they would like to speak with a nurse about, providing them an opportunity to discuss any other health concerns they may have. Many of the IVR identified issues do not require intervention by an RN, but can be addressed by other members of the healthcare team, such as assistance with doctor's appointments, getting prescriptions filled, or transportation. But as discussed earlier, positive symptoms are escalated to nurses who review the patient responses on our web portal and then reach out to the patient for further assessment and guidance, and who will also work with our customers' care coordination teams as needed. I'll now turn the program over to our next speaker, Jonathan Shankman.
Rosemary, thank you. So now we'd like to get into the nuts and bolts of the money-back guarantee offer. To begin with, this offer is for programs beginning in 2013 and beyond. Now, the implementation will include IVR telephone calls to patients recently discharged from the hospital, along with remote clinical oversight by the AMC Health telecare management team. When necessary, the team will escalate certain issues to customer liaisons and will notify physicians as per protocol negotiated with the customer. If, after a course of 90 days, AMC Health cannot reduce the all-cause readmission rate, and we'll get to how that's defined in just a moment, if we cannot reduce the all-cause readmission rate by at least 10%, AMC Health will refund the entire cost of the first 90 days of implementation. And I want to be clear here, there are no caveats. We will reimburse every billed element, no exceptions. Now, in terms of the required time frame and census for this evaluation, we'll need our partner to enroll at least 100 patients over a 3-month window who are at risk of readmission according to the assessment instrument chosen. The larger the number, the better, obviously. Now, 1 month after the end of that 3-month period, we will work with our customers to process the data, allowing us to compare 30-day readmission rates between the intervention and the control groups. Now, the way this will be calculated is that the all-cause readmission rate for the intervention population will be compared to the rate of a control population of equal or larger number discharged from the hospital in the same period as those in the intervention group. As for the definition of readmission rate, we want to be clear because we've had several questions about this. This is the straightforward calculation of the total number of all-cause 30-day readmissions divided by total census. So, for example, if there were 20 readmissions over a census of, say, 100, the rate would be 20 over 100, or 20%. Now, by 10% lower risk of readmission relative to the reference population, we mean 10% of the readmission rate of the reference population and not 10 full percentage points. So, for example, if the readmission rate for the reference population is 20%, the readmission rate for the intervention population must be 18% or lower. Now, the control group will use the same readmission risk criteria as the intervention group, and we will work closely with our customers to identify a suitable readmission risk tools, such as the LACE or the Boost AP risk assessment tools. Once again, the control and intervention groups should have been discharged from the hospital during the same time period to prevent confounders among seasonal and secular trends. And lastly, it's important that the control not consist of patients enrolled in a similar post-discharge IVR program. Now, just in summation, I want to make it clear that these requirements are all there are. We have no other fine print. Our purpose in issuing this offer is that we really want to convey just how confident we are in the power of this technology and in these processes to improve the scope and effect of what care managers already do very well. It works because it should work. And with that, I'd like to pass it back to Kevin for some final thoughts.
Thank you, John. In case you joined us late, I'd like to point out that AMC Health is a lot more than just the post-discharge IVR program. We also provide biometric remote patient monitoring, bidirectional video for remote visits, medication adherence systems for oral and inhaled medications, and a personal emergency response service. We've been referred to as a workflow management company by a number of our customers because we enable our customers to leverage technologies to redefine their care management models to improve care and decrease costs. Now I'd like to open the session up for questions. I see we've already received a number of questions from the audience, so if you just give us a moment to organize these questions, we'll be right back to you to begin the Q&A portion of our discussion. Hi, everyone. It's Kevin Quinn again. We have a few questions, not as many as we've seen in the past. So I just want to remind everyone that if you're submitting a question via the chat function, please select all participants in the Send To option before you send. And the first question we've received, actually there's several. Let me start out here with this one. If you're already deploying a readmission prevention program like Boost or Project Red, how would this program be different from these programs? I'm going to ask John Shankman to respond to that.
Thank you. That's an excellent question. I'm glad it came up. One of the points we're hoping to make clear during this presentation is that what we've learned over the years of deploying this is that it makes existing sound processes even better. Indeed, quite a few of our clients, including Geisinger, already had effective programs in place. If not specifically Boost or Project Red, then methodologies that were quite similar. But that doesn't change the fact that all of these great programs are still very heavily dependent on the human element and are challenged to scale as a result. I mean, look, the technology is not magic, and the right questions have to be asked, and the transition of care checklists have to be followed, whether it's Boost or some other process, but somebody has to follow up on that information and do something with it. So really it comes down to having live people make these gazillion of necessary connections, or weaving this technology seamlessly into these processes to make them far more powerful, more efficient, and more scalable.
Okay, great. Thanks, John. Another question came in. Why are you offering this money-back guarantee on this program alone and not on your other solutions or offerings? I'll take that one. You know, we really want to publicize this offering in response to a very pressing and immediate need. You know, thanks in large part to Obamacare and the CMS penalties for 30-day readmissions that started last October. We really want to get the word out so that people are aware of the solution and understand that there's a solution that can be deployed and that will start showing results in as little as 2 to 3 months. That said, we've also provided risk share agreements and opportunities for our other programs, and we'd be more than happy to talk to you about extending those for your patient populations as well. One thing to keep in mind, if you're thinking about a chronic care program, in those scenarios you typically won't start being able to see enough data until you're several months in, so it's not as immediate, the reaction or the ability to assess the the success of the program. All right, question came in. What patient populations seem to do best on these programs? For that, I'm going to ask Rosemary to reply.
Okay. There are many disease states, actually, that have morbidity profiles with higher readmission rates. CMS just identified heart failure, pneumonia, myocardial infarction, and COPD. So we see these fairly common. And then, again, any disease states and post-surgical. So many of our customers have gone and used all their lines of business, all discharges from the hospitals, and we've seen success with that. Patients also may be identified who score high readmission risk based on whatever assessment instrument that you yourself chooses. Reasons, again, when we're looking at these readmission rates, the reasons seem standard across the board. People don't get their prescriptions filled, they have falls at home, they have infections, and they fail to make doctor's visits according to their discharge instructions.
Thanks, Rosemary. Hey, another question came in. If biometric monitoring is used in the intervention group, is it also required in the control? John?
This particular offer for biometric monitoring, it does not employ biometric monitoring for this 30-day post-discharge program. So if you have a population in the control that is already being biometrically monitored through some other program, then we would probably suggest that they be removed from the control.
Okay, thanks, John. A question came in, what sort of ROIs have you been able to achieve? I'll respond to that one. The ROIs really do vary from program to program, depending on large part on the acuity of the patients being served. But for most customers using, our telemonitoring or telecare management services in addition to these technologies, we see ROIs of at least 5 to 1. I think this is a fairly conservative estimate, given that it doesn't really even include the savings that could be generated or achieved through productivity gains vis-a-vis your improved clinical efficiencies. But we feel very confident that the ROIs are quite significant with this program. All right, let's see. Question came in. What languages does the system support?
Right now, we provide basic IVR in English, Spanish, and Russian, but our system can handle literally any language. The way this works, and we maybe to step back, all of this IVR templates are delivered through live voice talent. These are not computerized statements. So we retain professional voice talent in all these different languages, and there's absolutely no reason we can't get them for additional languages as needed. Great.
Thanks, John. All right, next question. How long would it take to implement a program like this? Rosemary, want to take that one?
Okay, so we've actually implemented post-discharge programs in as little as 4 weeks. The main thing is working with our customer, doing workflow modeling. Again, we want to work with our customers so that they agree on our protocols and processes, so we have a plan in effect for escalations, and that the IVR templates that we use are customized to that customer's needs. So I think I discussed before that some people have a higher rate of hospitalization for pneumonia, others for other reasons. So we would like to get, those certainly we can adjust the IVR templates for. Another reason that it may take a little longer than that is that if we have to integrate data into your back-end systems, that would take a little more time. But again, we work with our customer every step of the way from beginning to implementation and beyond.
Thanks, Rosemary. Hey, John, I'm going to ask you to handle this one. The question is, I noticed the offer is only valid if we utilize the AMC Health nurse call center. Would this program work if we used our own case management or clinical team?
Sure. The answer, and we said before, is absolutely. As was the case with Geisinger, who used their own call center resources. Again, this technology is not magic. at the end of the day, it comes down to actionable information and what gets done with that information. And getting the data is really just the first step. So if no one is acting on this to bridge those gaps in care identified or prevent those pre-acute symptoms from boiling over, all the greatest technology in the world will not deliver these outcomes. So by all means, this is effective to make an already good process even better and to scale it and make it far more powerful. Now that said, for practical reasons, we're tying this offer to use of our care management services because we cannot guarantee results for a program that may not, for whatever reason, deploy the care coordination workflows that best assure that something gets done with this data and that the best chances exist for taking action on the information.
Great, thanks, John. Hey, John, let me tie another one onto you. It says, which risk assessment tool do you prefer for the control group?
Well, the same, to answer the question, the same tool has to be, the same processes for evaluation have to be used for both the intervention and the control. That's the whole point. Now that said, you know, in my personal opinion, the literature really doesn't overly support one of the standard tools over another, although authors of these tools might disagree. So many of our clients already use some of the standards like the LACE or the modified LACE or the Boost 8P. Geisinger used their own. We have many of other clients who have their own homegrown tools. Honestly, it's you know, one over the other is not our concern as long as it's consistent and applied equally between the interventions and the control. And just, you know, if we're more than happy, and we do work with our customers very closely to help them identify the best risk assessment, readmission risk assessment tool that fits their unique post-discharge profiles.
Okay, thanks, John. All right, question, what resources will I need to commit to get this program up and running? And I'll respond to that one. This is honestly a very, very good question. It really, you know, we really started and came up with this offer with the idea that we'd be able to provide the clinical and case management to enable the customers to see how effective this program could become with as little expenditure of their resources as possible. What we anticipate kind of seeing once a proof of concept or proof of use is established is many organizations may want to pull this back in-house to incorporate it in their own care management teams or clinical services to drive greater efficiency and ultimately improve the quality of care that they're providing the patients. So we really work with our customers to ensure a successful transition, and we really work with customers to automate to the greatest extent possible the transition of data by and between our organizations so that it becomes a very natural flow and contribution to the workflow of the clinicians involved, and requires very minimal manual intervention, if you will. Let's see, what do we have next? All right, here's a question. It says it's clear you've been able to make this work in an integrated system, but have you experienced deploying this among physician practices or even within home care? John?
Sure. The answer is absolutely. In fact, we're getting a steadily growing amount of attention from provider-based ACOs and the PCMHs with whom they contract. And the same goes for home care providers. As new as they are, it's interesting, the ACOs have been surprisingly prescient in seeing how this technology will help them achieve their targets. So clearly it's not just the hospital systems interested in readmission reductions. As we're seeing more and more provider groups enter into these risk-based or incentive contracts, they are fast becoming aware that the lifeguard's blown the whistle and that free swim is over. The only way they're going to survive is to keep their patients out of the hospital, end of story. Honestly, we've come a long way from when this data was considered more of a liability to provider groups when, after all, they got paid no matter what. So what they didn't know didn't hurt them. To the contrary, greater insight into what was going on in the home elevated their risk of liability. Sad truth, but it's a very different world now, thankfully, and having everyone with skin in the game with outcomes-based reimbursement, I think it's a good thing for the country. and providers and home care entities are fast learning that it's adapt or die.
Okay, great. Thanks, John. Here's a question. It says, you briefly mentioned the automated telephone call. Is the call due to the patient non-responding to the sessions, or could you basically, I guess, elaborate on the reason for the automated call? Rosemary?
Actually, the automated calls are the crux of the program, and I'm going to assume this question is referring to perhaps a tabletop device. We found that telephone calls are much more natural to people, and thus the interactive voice response system, where an automated call is sent to the patient, eliciting them to respond to the questions, such as, have you made a doctor's appointment after your discharge? Have you gotten your prescriptions filled? So those are the actual calls that go out to the patient, and in this model, we've not discussed a tabletop device.
Thank you, Rosemary. All right, here's another question. It says, the detail of the offer excludes patients who have received special services designed to prevent readmissions. If we have already implemented a program for all discharges, does that mean the money-back guarantee does not apply? John Holland, could you take that one?
Sure. No, it doesn't mean it doesn't apply. John did mention that the only thing we would exclude would be for a control group would be patients who are already receiving an IVR-based intervention similar to this one, but from a different vendor. So if they're in Boost or Red or any other project like that, absolutely eligible. We think that this will be additive, and we're happy to join in.
Thank you, John. Okay, I'm just kind of scrolling through some questions here. Honestly, there's several questions that seem to be a little off topic, and I think if we don't cover your question here today, we will reach out to you to cover individually. So please, if we don't cover your question, don't worry, we will get back to you. Now I'm receiving questions through the Q&A function as well as the chat, so I'm just kind of looking between the two to make sure I cover them. Okay. All right. So, all right. Here's one. We already have one of the lowest readmission rates in our state. For those of us in danger of triggering the CMS penalties, it's hard to justify the costs and efforts to deploy this when our hospital has more pressing concerns. I guess they're just looking for a reaction from us on that. John, any thoughts?
I think you meant by those of us in no danger of triggering the CMS penalties. But, you know, we hear this a lot. But that doesn't stop clients with truly stellar readmission rates from signing on, because they understand that they got to those great numbers through an intensive transition of care program that relies on a huge human asset base that is not sustainable and certainly not scalable. I mean, look, in our world, questions about outcomes really come in two basic varieties. First, were we able to achieve better outcomes through the application of this technology than through usual care alone? But the other fundamental question is, and it doesn't get asked often enough, is were we able to get similar outcomes, but we're now able to conduct this program more cost-effectively, more efficiently, and scale it faster given the efficiencies that can be leveraged from this technology. So we're happy to say that we're typically able to deliver on both. So we welcome customers with already terrifically successful programs, not only because good should never be the enemy of better, but even those in this fortunate position need the tools to scale, because you know, let's be honest, you cannot possibly hire enough staff to get to where this needs to go.
Okay, thanks, John. Folks, we're just going to put it on mute for a moment here. I just want to, we've been kind of jumping around a little bit with regard to the questions that are coming in. I just want to make sure we've got our arms around everything.
Kevin, before we do, I'd just like to clarify an answer I gave earlier, because somebody had a further question about it. The issue about whether if you're using some other readmission prevention program, you'd be eligible for this. So it's actually a two-part answer. Yes, in both cases. Yes, patients can participate in the money-back guarantee program if they are on another program as well, as long as it's not another IVR program. And the only issue with the control group is that they have to basically be getting the same thing that the intervention patients are getting so that it's a fair control. Thanks.
Okay, folks, we'll be right back. All right, folks, it looks like where I was reviewing the all panelists inquiries that were coming in, we also got several that went directly to our host. So John has access to those. I'm going to ask John to read some questions as well.
One question was, please speak to how we prepared people for the IVR calls, i.e., how did you obtain such a high level of adherence to patients responding to the calls? I'll ask Rosemary to do that. She's most intimately involved with that.
Okay. Actually, when we get people in the program or referred to the program, what we found after much trial and error is that we really need to explain to them the IVR call. Again, they're automated calls that go out to them, and most people inherently hang up when they get a call that's automated. So our engagement specialists work very closely with each patient to explain the script of the call, the purpose of the questions, how the answers are used, and they actually go so far as to send the first call out to the patient once the engagement process is finished at that very same day.
Thank you, Rosemary. Here's a question. Any analysis on what kind of patients are more or less responsive to automated voice prompts? I'm sorry, did we cover that one already?
Yeah.
Oh, my apologies, folks. Let's see. At what point or how does the patient get enrolled in the program? John?
Sure. Essentially, there's two vehicles. One, in larger programs, we get batch data feeds as part of an integrated process with, where our systems are linked in such a way that referrals are automatically dumped into our system. The other option is, and then we go about performing the engagement on these batch buys. The other process is really ad hoc referrals made directly to the AMC Health web portal, where the patient information is logged in, and that triggers the process to begin engagement and reach out to these people.
Great, thank you, John. Hey, folks, I see a few folks are starting to log off, so I just wanted to make a plea, a request, if you could. You'll be receiving a survey following the webinar. If you could please just give us maybe 2 or 3 more minutes of your time to complete the survey, it'd be greatly appreciated. Obviously, we're very interested in how we can continue to improve the value of these webinars going forward. All right, I did bounce around, so it makes it tough for me to keep track of what we've already asked, so my apologies. But a question came in, how is video conferencing conducted to the home?
The answer is, although we do employ in our other programs bidirectional televideo for remote consultation, remote treatment, remote diagnostics, that level of technology is not typically deployed in a 30-day post-discharge program. So this program we described only involves IVR, and that IVR, by the way, I know Rosemary touched on this, can be delivered either telephonically to any phone number, including cell phone numbers, but it can also be delivered as SMS text messages, so as message prompts. So for those who are hearing impaired, they can receive it that way. But this is entirely a telephonic process with no additional technologies required.
Great, thank you, John. Folks, I think at this point we've covered just about all the questions we've received. If you have any other questions, please feel free to submit them. Also, as a reminder, please do complete the survey. If at any point you have any questions that we might be able to help you with, feel free to contact me. My contact information is displayed on the Q&A screen. I just want to thank everyone for attending this afternoon. Thank you so much, and have a great day.